During the period of inactivity, no symptoms are present, only skin thin, dark, scar, poor nourished past sinus and ulceration that is not easily healed. Muscle wasting, contracture and atrophy, joint stiffness, bone thick, sclerotic, often contains abscess cavity. At intervals, flare-up may occur. The relapse is often the result of poor body condition and lower resistance. A lighting up of infection is manifested by aching pain that is worse at night. Locally, there will be some heat, swelling, redness, tenderness, edema, because pus may build up in cavity, then a sinus may open and starts to exudate purulent material and small sequestra. The sinus closes and the infection subsides. The laboratory findings, the white blood cell count will show marked leukocytes as high as 20,000 or more. The blood culture demonstrates the presence of bacteremia. The blood must be taken when the patient has a chill, especially when there is a spiking in temperature. The aspiration should be done. The point of maximal tenderness should be aspirated with a large pore needle. A thick pus may not pass through the needle. Any material aspiration should be gram stain and culture to determine the sensitivity to antibiotics. In patients with Cernimeter stage 1 or hematogenous osteomyelitis, positive cultures of blood or joint fluid is diagnostic. Definitive diagnosis obtained from intra-biopsy samples. Best samples are tissue fragments directly from the center of infection. If possible, culture specimen should be obtained before antibiotics are initiated. The empiric regime should be discontinued for these 3 days before the collection of sample for cultures. Culture of specimen from the sinus tract are not reliable for predicting which organism will be isolated from the infected bone. The X-ray films are negative within 1 to 2 weeks. Careful comparison with the opposite side may show abnormal soft tissue expansion or soft tissue shadows. It must be expressed that X-ray experiences are normal in acute phase. There are little value in making the early diagnosis. By the time there is X-ray evidence of bone destruction, the patient has entered the chronic phase of the disease. It takes from 10 to 21 days for an osseous lesion to become visible on conventional radiography because a 30 to 50% reduction of bone density must occur before radiographic change is apparent. This is the X-ray picture showing chronic osteomyelitis. Localized osteopenia and trabecular destructions are early signs of a suppurative acute process in the bone. Type and extent of cortical destruction is variable. A wide spectrum is encountered, ranging from a solitary radiolucency to irregular multiple radiolucencies or mottling to a permeative pattern. The individual lesions are generally indistinct and regular in outline. Ultrasound cannot directly access the bone marrow abnormalities present in osteomyelitis but can document osteomyelitis indirectly by identifying periosteous soft tissue abnormalities. The very first sonographic sign seen even before any periosteal reaction is edematous swelling of the deep soft tissue. Bone scans are useful. Radioisotopic scanning is valuable in early localization of bone infection. The specificity of radioactive isotope imaging techniques have improved in the evaluation of musculoskeletal infections. Technetium-99 imaging is very sensitive. It is the choice for acute hematogenous osteomyelitis, the overall accuracy being 92%. MRI has a very high sensitivity and specificity. The advantages are useful for differentiating between bone and soft tissue infection, helpful in surgical planning. The disadvantage is that a metallic implant in the region of interest may produce focal artifacts, false positive in tumors and any fractures. So early diagnosis depends on severe acute illness, rapid onset and toxemia, local severe pain and unwillingness to move limbs, deep tenderness, high WBC count. The pathogen is isolated from bone or adjacent soft tissue if there is histologic evidence of osteomyelitis. Is it definite? The probable is criteria is a blood culture is positive in setting of clinical and radiological feature of osteomyelitis. And the likely is the typical clinical findings and definite radiographic evidence of osteomyelitis are present in response to antibiotic therapy. Differential diagnosis of osteomyelitis, tuberculosis. The tuberculosis will have thin watery discharge. The tubercular osteomyelitis will have thin watery discharge, undermining of edges, and bluish discoloration. Diphyseal involvement is more common. History of pulmonary tuberculosis is often present, often multifocal. Soft tissue infection, abscess of bony changes. Ewing sarcoma will have radiological differential diagnosis, acute presentation. It can be due to foreign body, osteodyostema, histiocytic eosinophilic granuloma, and Gers osteomyelitis. Now the treatment. The general treatment is nutritional therapy or general supportive treatment by intaking enough calories, protein, vitamin, etc. The antibiotic therapy, surgical treatment, and immobilization. Now there are a few principles that are known as NETS principle for treatment of chronic osteomyelitis. Antibiotic is effective before pus forms. Antibiotic cannot sterilize avascular tissues. Antibiotic prevents reformation of pus once removed. Pus removal restores periosteum and restores the blood flow. An antibiotic should be continued even after surgery. Now the prospective evaluation of a shortened regime of treatment of acute osteomyelitis and septic arthritis in children. It included 70 consecutive eligible children aged 2 weeks to 14 years. Staphylococci were the only organism isolated in the cases of osteomyelitis. It found that 59% of children could be converted to oral therapy after 3 days of intravenous therapy and 86% after 5 days. It established that 3 weeks of oral therapy was appropriate for those patients who received 5 days or less of intravenous treatment. Now there are next indication for surgery. These indications are abscess formation, severely ill and moribund child with features of acute osteomyelitis, failure to respond to IV antibiotic for more than 48 hours. The complications osteomyelitis leads to acute osteomyelitis leads to chronic osteomyelitis 2% in more than 3 weeks and 19% in less than 3 weeks. It can lead to septic arthritis due to involvement of joint. It can lead to growth disturbances due to physeal damage or bone deformity. It can lead to septicemia, deep vein thrombosis, pulmonary embolism. Now, what is subacute hematogenous osteomyelitis? It is more insidious onset and lacks the severity of symptoms. Diagnosis typically is delayed for more than 2 weeks. A pathogen is identified only in 60% of the time. Staphylococcus aureus and Staphylococcus epidermidis are more commonly involved. The diagnosis often must be established by an open biopsy and the culture. What is Brody's abscess? A bone abscess containing pus or jelly-like granulation tissue surrounded by a zone of sclerosis. It is common in age between 11 to 20 years. Metaphyseal area, usually upper end of tibia or lower end of femur. Patient has deep boring pain, worse at night, relieved by rest. Circular or over lucency surrounded by zone of sclerosis. The treatment consists of conservative treatment if no doubt, rest plus antibiotic for 6 weeks. If no response, surgical evacuation and curettage if large cavity pegged with cancellous bone graft. This is picture showing chronic osteomyelitis of the femur. If any of sequestrum, abscess cavity, sinus tract or cloaca is present, it is known as chronic osteomyelitis. Hematogenous infection with an organism of low virulence may be present by chronic onset. Infection introduced through the external wound usually causing a chronic osteomyelitis. It is due to the fact that the causative organism can lie dormant in the vascular necrotic areas, occasionally becoming reactive from a flare-up. The Cerny et al. Has classified chronic osteomyelitis includes four anatomical stages. Stage 1 is intramedullary, 2 is superficial, 3 is localized, and 4 is diffuse. The medullary or stage 1 osteomyelitis is confined to the medullary cavity of the bone. The superficial osteomyelitis involves only the cortices of the bone. The localized osteomyelitis usually involves both cortical and medullary bone but does not involve the entire diameter of the bone. And the diffuse osteomyelitis involves the entire thickness of the bone with loss of stability. With this system, patient with osteomyelitis is classified as an A, B, or C host. An A host has no systemic or local compromising factor or is not immunocompromised. Type B host is affected by one or more compromising factor, which is BS, that is systemic compromise, BL, local compromise, and BL as both systemic and local compromise. A type C host is so severely compromised that the radical treatment necessary would have an unacceptable risk-benefit ratio. This is Cerny classification or staging system. This is this is a diagrammatic representation of the classification. Type 1 medullary confined to medullary canal only. Type 2 superficial confined to cortices only. Type 3 is localized and type 4 is diffuse. During the period of inactivity, there are no symptoms, only skin thin, dark, scared, poor nourished, fast sinus and ulceration that is not easily to heal. Muscle wasting is present, contracture atrophy may be present, joint stiffness sometimes present, bone is thick and sclerotic, often contains abscess cavity. The clinical features at intervals, flare-ups occurs. The relapse is often the result of poor body condition and lower resistance. A lighting up of infection is manifested by aching pain that is worse as night. Locally, there will be some heat, swelling, redness, tenderness, edema because pus may build up in cavity. Then a sinus may open and start to exit purulent materials in small sequestra. The sinus closed and the infection subsided. This is the X-ray picture showing sequestrum surrounded by periosteal new vein formation that is involucrum. The sequestrum is at the center and it is surrounded by involucrum that is periosteal new vein formation. Sinography is useful. Sinography can be performed if a sinus tract is present. Sinography can be performed if a sinus tract is present. Röntgenograms made in two planes after injection of radiopaque liquid into sinus. It is helpful in localizing focus of infection in chronic osteomyelitis. What is Gers osteomyelitis? It is sclerosing non-suppurative osteomyelitis, more common in jaw. There is no abscess, no cortical thickening, acute local pain, pyrexia subside, fusiform swelling, acute stage, rest and antibiotics are needed, surgical treatment, gutter holing, excision and curettage. Now the role of antibiotics. So IV antibiotics, there are various antibiotics. After proper culture and antibiotic sensitivity testing, one should give suitable antibiotics. Rifampicin is the first line anti-Staphylococcus aureus antibiotic in chronic infection. It reduces intraleukocytic bactericidal action. Now there is saying for osteomyelitis to wait is to invite disaster. The surgical treatment comprises of bone debridement. The goal of debridement is to leave healthy, viable tissue. Debridement of bone is done until punctate bleeding or pinpoint bleeding is noted, giving rise to the term the paprika sign. Copious irrigation with 10 to 14 liters of normal saline. Pulse lavage or pulsatile lavage using fluid pressure 50 to 70 pounds per square inch and 800 pulses per minute. The extent of resection is important in B host as B host treated with marginal resection found to have a higher rate of recurrence than normal host. Repeated debridements may be required. This is picturesque representation of removal of the sequestra and packing with bone grafts. Now, when to do sequestrectomy? Early sequestrectomy eradicate infection, better environment for periosteum to respond. Delayed sequestrectomy, wait till sufficient involucrum has been obtained before doing a sequestrectomy to minimize the risk of fracture, deformity, and segmental drops. In either cases, it is critical to preserve the involucrum. It is preferable to wait at least 3 to 6 months before performing sequestrectomy. What are the prerequisites for sequestrectomy? There are radiological and clinical requirements. Radiologically, there should be well-formed involucrum surrounding the discretely visible sequestrum adequately at least two-thirds diameter of the bone, and clinically symptomatic patient with pulse discharge or chronic unrelieved disabling pain due to osteomyelitis as per type A or B host. There is a surgical procedure termed saucerization. It is extension of surgical debridement. Debrided wounds left open widely through excision of overhanging soft tissue and bone. Wounds drained freely, abscess do not form. Limited to areas where it causes acceptable loss of function, that is tibia and femur. Now, how to manage dead space after debridement? Adequate debridement may leave a large bone defect termed dead space. It is a predisposing condition for the persistence of infection because it is poorly vascularized. Appropriate management of any dead space created by debridement is mandatory to arrest the disease and to maintain the integrity of the skeletal part. It helps improve local biological environment by bringing in a blood supply important for host defense mechanism, antibiotic delivery, and osteogenesis soft tissue healing. The goal of dead space management is to replace dead bone and scar tissue with durable vascularized tissue. Can be managed by free vascularized bone graft, local tissue flaps or free flaps, cancellous bone graft, and open cancellous graft. Now, the dead space is managed in stages. First stage is of debridement. Second stage is cancellous bone grafting after entire cavity is covered with granulation tissue. Third stage is wound coverage. It can be in form of spontaneous epithelialization, split skin graft, or the flap cover. Muscle flaps are needed to cover the large defects, increase the blood supply to that area. Gastrocnemius flap is most commonly used. Indications are adjacent soft tissue cannot cover the area. Area should anatomically permit transportation of a local muscle flap without compromising its neurovascular bundle. Debridement procedure hasn't compromised the mechanical integrity of the osseous structures. The vascularized musculocutaneous flaps are used. Antibiotic beads may be used to manage the dead space. Beads are made with polymethyl methacrylate antibiotic coated cement. Closed suction drains are also used. The drain comprises suction double lumen catheter tubes with separate stab wound for early antibiotics delivered. If there is instability, the bone needs to be stabilized. If skeletal instability present at the site of infection, measure must be taken to achieve stability with plates, screws, rods, or external fixator. The external fixator is the preferred over internal fixation because of tendency of the sites of medullary rods to become secondarily infected and to spread the extent of the infection. Sometimes limb reconstruction is required. Elizarov is the gold standard of external fixator for limb reconstruction. It is used for reconstruction of segmental defects and difficult infected non-unions. Based on the technique of distraction osteogenesis, whereby an osteotomy created in the metaphyseal region of the bone is gradually distracted to fill the defect. Amputations are the treatment choice as a last resort. It is infrequently performed. Indications are If there is malignancy, arterial insufficiency, nerve paralysis, or joint contraction stiffness making limb non-functional. Complementary therapies are there. Hyperbaric oxygen augment host immune system, allow formation of peroxides, promote wound healing. Electrical stimulation, direct current, inductive coupling for non-union with acceptable alignment. Ultrasound in low intensity. Complication of chronic osteomyelitis are acute exacerbations which are more common. Growth abnormalities, deformities. It can lead to pathological fracture, joint stiffness, amyloidosis, malignancy. Most common is squamous cell carcinoma, septic arthritis of hip, knee, ankle, shoulder, and other joint. Thank you very much. We are done with our topic chronic osteomyelitis. Thank you.